Dr. Jalali will speak about macro surgery in newborns.
Thank you. I think for many of people, it's like the babies don't have a macula and they don't get macular disorders. So after operating more than 8 to 9,000 cases, I'll try to tell in 4 minutes, little bit, just the beginning, just to, tickle your taste buds about macula in babies. Thank you, Dr. Mohammed and Dr. Abdullah and MUM for having me here. So what is different in the macular pathology of infants? I think the macular configuration in infants depends totally on the presence or absence of the persistent fetal vasculature component. The second thing is that the infantile retina can stretch as it is elastic, just like the infantile cornea stretches when they get high pressure, and this doesn't happen in adults when they get high pressure or when they get a detachment. So in adults with detachment at the macula, you get a tabletop detachment, but you don't get a stretch retina. The important thing is that it is often a progressive disease. The vision and the potential vision progressively decline if we don't take care of this macular fetal vasculature pathology. So I'm just showing here two pictures of tractional detachment in ROP. So in the right, the first picture, you can see there's a peripheral traction, but the macula is unaffected because there's no persistent fetal vasculature stalk. Whereas in the other one, immediately there's a dragging of the macula and closure of the arcades because there is inside that fetal vasculature stalk, which is what is dragging it towards the lens and towards the peripheral retina. So here we are just seeing these are two eyes of FEVR in two cousins. You can see why the configuration is different. The one with a lot of macular fold is because that eye also has an additional component of the persistent fetal vasculature stalk. Whereas where it was not there, you can have components of peripheral circumferential traction, but the macula doesn't close. So these configurations will depend on the different configurations you see will depend on what is the lens addition to that stalk and where it is arising. Is it arising in the middle of the disc? Is it arising on the nasal side or the inferior side? So these tractional folds can be different in different areas. But it's not just the ROP and FEVR which have persistent fetal vasculature stalk. Many people miss out about that persistent fetal vasculature stalk. For example, in Coats disease, you can see an eye without the stalk and another eye with the stalk. Same way here, epiretinal membrane in children, they can occur in hematomas and other things. But if there is a stalk there, and I'll show the surgery of this second one, then it will have a different configuration. The whole arcade will come together around that stalk because that acts as a scaffold to drag the retina towards the disc and towards the lens. So I hope this video will play. So
this video is of a 2-year-old child who has retinal hematoma with epiretinal membrane. So we do a core vitrectomy and try to look at the areas where we can find a edge where we can lift the epiretinal membrane. So here we are seeing now that there is a vitro membrane adhesion. We found the edge and there was a good edge here. You can see the ERM is between the drag disc and the fovea and the surrounding macular area. We are now using sequentially the end gripping forceps and the vitrector to lift and create a plane between the
so that's the stalk which was between the disc and the fovea.
Hematoma and the retina. Usually the membrane does come out quite pretty well easily. It's not very adherent, but there would be retinal folds under that membrane, and that is what we have to be very careful about. So the retina would be thrown into undulating folds under the membrane, and we should be very careful. But otherwise, as you saw, it does come out pretty easily, and it's not very difficult to remove. Some area of suspicion, we can do laser under the air. You can see here some little bit of laser we did and then closed after giving a
so these are sutureless surgeries. We can do sutureless surgeries. Then another case.
This video is of a 3-year-old child where we are doing vitrectomy for a FEVR fold. So I wanted to depict how to manage the retinal fold and the persistent fetal vascular, which is very often associated with these folds in FEVR cases. So as you can see here, there's some vitreous hemorrhage, active vitreous hemorrhage, and that is the reason why we are operating this case. Many people would have just done a laser, but that doesn't work because as you will see in the video, there's a lot of vitreous covering that avascular retina. So we are trimming this persistent fetal vasculature stalk, which is going from the disc to the periphery. Near the fovea, there'll always be a very dense attachment. You can use a scissors or a bimanual technique, or if you are deaf, then you can definitely release that traction slowly around the fovea as you see here. So there will be a stalk and there will be surrounding vitreous which is causing that fold. Be extremely careful not to eat away that fold of retina and create a disaster. So slow trimming of the stalk which will relieve the traction which is worsening the fold. We are not going to open that fold. We are not going to do anything to the fold. We are only relieving the traction so that in future, this video is of a.
So, of course, these stalks can also lead to exudation. You can see here, this child was going around the country not being operated, saying that nothing needs to be done. And you can see immediately after surgery, once you've trimmed the stalk, all the exudates go away. And so I just want to conclude by saying that macular surgery of infantile onset retinal conditions should take into account the variable disc and foveal adhesions of the persistent fetal vasculature stalk, which causes undulating retinal folds, and there can be variable attachments. Sometimes they're adhesion to the central retinal artery, and if you pull it, you might create an avulsion of the central retinal artery. So you have to be very careful, watch carefully where the vessels are, where the tissue is. And these foveal adhesions, as you saw in the two videos, they could be like a surface plug, which will come out very easily, as in the first video. There could be a deeper plug where you have to trim it, or sometimes it has multiple tentacles, and sometimes it is a full thickness scar tissue where you just trim around it and leave it there. Thank you.
Thank you, Dr. Jalali. Very nice, informative, as usual. We'll open the floor for discussion. Any question? Yeah, I know you're going to ask. Yeah, Dr. Shangal.
Thank you for the great talk on especially the PFE stuff. I believe that PFE stuff plays an important role in most of the pediatric retinal problems, and we have newly published our data on the similarities between combined hamartoma and the PFE. I believe that combined hamartoma may be in the spectrum of PFE, and it may be kind of form a fruste form of, or, very kind of mild form of PFE, just without any stalk, but it usually leaves a membrane there, and most of them have a small, very small elevation, at the center or somewhere. And we have published this data, and I'm happy it's published. And I know that in ROP cases, in fever cases, when you have the PFE stalk associated, it's a kind of more severe disease. So thank you for emphasizing that.
Yeah, even when you're giving anti-VEGF, if there is a stalk, those eyes don't do as well, and they can actually bleed after the injection as compared to the stalk, and they regress much less. So I think there's much more to the stalk. We are still learning. Thank you.
Dr. Jalal, one more question. Yeah, maybe I have one question, Dr. Muhammad as well. So,
Dr. Jalali, very nice presentation. Do all folds stretch after you relieve traction, or sometimes encounter persistence of the fold post-operative? And what are you going to do in such cases?
So the fold, how much it will open will obviously depend on when you operate it. If you operate them very early, before they have closed, they will all go absolutely normal. The retina will go back, it will fall, the eye will grow, and the folds just go away. But if you operate when the fold is already closed, then we usually, let it be there. The rest of the retina opens. The whole, these neonatal surgeries depend on the growth of the eye. So if the child is already 3-4 years old, then the surgery will not work as much. But if it is few months old, then it works much more. The other way to open that fold is, we have some other presentation, is using a sclera imbrication. If you use sclera imbrication, the globe becomes smaller and the floor opens up. So the fold opens up. That is if there is a component of a regard with traction, but sometimes even for traction we've done that. Learning more.
thank you, Dr. Jalali. Thank you very much.